who's got a very long series of titles, but basically she's pathologist in chief and medical director at the University of Toronto. Sylvia.
Thank you very much, and it's a pleasure to be here to tell you a little bit about our experience in Canada. I'll just preface it by saying that we don't have an FDA. So I'm just going to start with a couple of disclosures. My institution is a member of the Omnix Collaborators Program, and I'm a member of the Apereo Medical Advisory Board, but I receive no financial compensation from either of these companies or from any other digital pathology vendor. So I'm assuming most of you are here from the United States. Just to remind you about Canadian geography, we're just north of you, not too far away. It only took me an hour to fly here from Toronto. We're a very large country. All of our population is concentrated at the American border along the southern end of the country, and we have public health care enshrined in our federal law. We are not allowed to have any private health care. So given that setting, I'm going to tell you a little bit about the background of telepathology and whole slide imaging, our specific experience in Toronto. I'm fortunate to also have some slides given to me from a colleague in Quebec, and I will show you some of the Quebec application and how we are transitioning to digital pathology and how we envisage the future in Canada. So most of you in this audience know the historical side of this. Telepathology was originally created for remote diagnosis back in 1973 from Brazil to Washington, D.C. In '86, Ron Weinstein coined the name, and then throughout the '90s, Norway really led the way with robotic microscopy to support a very remote population without pathologists on site. So the question really is, if telepathology was created for supporting remote locations, how remote does remote have to be? So I'm going to challenge you with that and tell you our story, which started with a consolidation of 3 University of Toronto affiliated teaching hospitals that really structured, they were 2 general hospitals and 1 cancer hospital. They started off in different locations. One moved next to another, but one was still about a mile away. I'm going to show you that in a second. And we basically had programmatic restructuring to consolidate clinical programs at each hospital. So here's the geography of downtown Toronto. Actually, I'll just point out the, if I can use this pointer. There it is. The Government of Ontario sits right here in Queen's Park, and the Toronto General Hospital is Toronto's largest hospital right across the street from the main government. This was a large general hospital which has become a center for cardiac care, transplantation, and complex medical and surgical procedures. Immediately across the street from it in 1996, we renovated an old bank and made it into our cancer hospital, the Princess Margaret Hospital. There is a tunnel that attaches these two, but it has to go underneath a subway. It's very complex, and most of the time we run across the street, which can be physically challenging, but that's okay. And then the Toronto Western Hospital was Toronto's 2nd largest general hospital. That distance is approximately 1 mile, and that became our large center primarily for neurosurgery and orthopedic surgery, but also because of the amount of space in the operating rooms, it became a center for minimally invasive surgery as well. So when I joined this organization in 2000, my job was to consolidate 3 departments of pathology into 1. And what we did was we consolidated the entire group at the building that had the most space for pathology, where we could integrate all the pathologists and all the labs that we need. And that happened to be at the Toronto General Hospital, which was the largest building and had construction ongoing at the time. The challenge was that we had no plans to have an on-site pathologist at the Toronto Western Hospital, and to provide support for a very low volume of intraoperative consults, we really didn't understand how we were going to be able to do this, have a person sitting there on-site all day long and still be integrated into the department and provide diagnostic services in other areas as well. So we investigated the concept of telepathology. Now, just to kind of give you a bit of background on how we did this, it was kind of novel at the time. So we actually did a fair amount of due diligence, and I have to give Andy Evans a lot of credit for this. Andy is the director of telepathology at UHN now. He had just joined staff. He was young, bright, and computer savvy, and I asked him to take this on as his project, and Andy was very meticulous. He actually wrote to our malpractice insurance provider and requested information about what this would mean for us. Canada's fortunate. We have one malpractice insurance provider for the entire country. It's called the CMPA, Canadian Medical Protective Association. They're not for profit. All doctors are members. We all pay our dues. We get back what's not spent at the end of the year, so it's a very democratic system. They investigated this and said that telepathology would not affect our coverage. We took the process to the UHN Medical Advisory Committee. We showed them our SOP that we were going to use, and they were quite happy with it. We spoke to Health Canada, which is the equivalent of the FDA in Canada, and at the time they said telepathology does not involve a medical device because there was no direct contact between the instrument and the patient. We were a lot smarter then. The FDA set us back a little bit, but we still don't have an FDA, so we're okay on that end. So then our next job was to work with our surgeons at the Toronto Western Hospital, teach them how we were going to do this, show them what the robotic microscope and ultimately the slide scanner was all about, and we got their buy-in to the concept. So we started in 2004 with a robotic microscope. You can see here Andy Evans himself sitting at the Toronto General Hospital at the workstation. Here is one of our technologists, Suganthi, who is actually preparing the slide and then putting it on the robotic microscope. In 2006, we were sufficiently convinced that whole slide imaging was a much better process, and we implemented that instead at the Toronto Western site. And you can see what the images are like. We were using a Perio alone at the time, and we developed a protocol with a system test every morning. Whoever was on call to cover frozen sections at the Toronto Western Hospital, and we had a separate roster for that, they would review the OR list, communicate the plans for the day to the technologist who was on site. We worked with our surgeons. If it was a neurobiopsy, obviously there was nothing to talk about, but if it was a large specimen or something coming out of a minimally invasive surgical procedure, the surgeon would identify the tissue of interest that they wanted a frozen section done. We do have a pathologist on site at all times. We also have a web camera, and so if there was any question, the pathologist could see the gross specimen. The histotechnologist would then contact the pathologist, tell them what was going on. They would cut and stain the tissue and then call the pathologist. When the pathologist had reviewed the material, they'd call into the OR, and then every specimen we did, of course, was QA'd the next day. We learned a little bit about failure mode analysis. We had a network failure one time. It was due to the fact that the scanner had moved from one spot to another in the surgical pathology lab, and we didn't realize that we had dynamic IP addresses. So that was a little bit of a problem, so we convinced our IT folks to go to static IP addresses. Every morning we ended up doing this test run so we would avoid anything like that. We also had one mid-case failure where a small piece of tissue that the scanner didn't recognize was not there, and so we couldn't actually see the image. We had to rescan it. And we also learned that excess mounting media causes a cover slip to stick to the scanner objective. So we've learned to do routine maintenance on the objective and to make sure that our slides don't have too much mounting medium. Now, some data from about last year sometime. We've done more than 2,000 frozen sections from that site on 1,700 patients. 90% of these are neurosurgical. Our accuracy, 98 concordance with final surgical pathology, which is exactly identical to our on-site rate when we do frozen sections at any of our other sites on-site. This is not a function of the digital technology, the whole slide imaging or telepathology. It's just due to the fact that sometimes we don't know what the specimen really has in it. Our deferral rates, again, identical to what we have on any of our other sites where a pathologist is in the room. And our turnaround times, 14 to 16 minutes, less than the 20 minutes required by CAP. And by the way, we are a CAP-accredited lab, even though we're in Canada. And 70% of our cases are reported in less than 2 minutes after the scan is received, which is exactly similar to what the results are like using a microscope in one of our other sites. So we then decided, with our interest in this digital pathology, we said, well, what else can we use telepathology for? So how remote is remote? Well, I told you 1 mile away is remote enough. But what about the need to reach a specific expert? So let me just tell you a little bit about the model of our department, which has evolved over the last 10 years. We have a highly subspecialized anatomic pathology group. We believe this is faster, better, cheaper. And that's my mantra. All cases cases are reported by a pathologist who has expertise in the specific subspecialty that's required. GU is reported only by GU pathologists. Breast is reported only by breast pathologists. We have every subspecialty you can imagine. Even endocrine is a subspecialty in our group. As I said, I think this is faster for the patients because they get the right answer from the expert immediately. You don't have to wait for secondary consultation. It gives better quality diagnostics. And for us in a public health care system, we feel this is more cost effective because you don't pay a generalist to review a case first and then refer it to the expert. The expert does it right away, so we get much better, cheaper care. And our pathologists love this. We're an academic center. It allows people to focus on their academic interest, write papers, see lots of material, all the esoterica, etc. I don't think I need to convince an academic about the benefits of subspecialty practice. The challenge for us is, of course, having appropriate staffing in all areas. And when I started, we only had 24 pathologists, which makes it a challenge to have subspecialty coverage with backup for vacation times and all the rest in every area. However, we moved ahead with this model, and of course using the system that we had set up for our telepathology, it meant that we could then offer subspecialty backup for frozen sections as well. So our roster has people rotating on frozen section service. We don't have a policy of primary subspecialty frozen sections, but if somebody encounters a case which is outside their area of expertise and they're not quite sure what it is, they can call upon the subspecialist of interest, and that person doesn't have to run down to the OR no matter where they are, even in the same building. They look at the slides that are scanned digitally and they're able to give that subspecialty diagnostics. The other challenge we faced is that as academics, our pathologists always want to go to meetings, and you all know what that's all about. So our first challenge that we faced back in 2008 was how do we get our 2 liver pathologists to read transplant biopsies supporting a very large liver transplant program and still be able to attend USCAP, liver pathology meetings, and even a course in India where they were both invited to speak. So we set up a system where all liver biopsies are scanned and read by these folks. They're connected with their laptops no matter where they are in the world. They never get vacation anymore, and they're still very happy and still work for me. And then, of course, the question of weekend coverage came up. Why do I have to come into the hospital when I'm called for a frozen section if we have this fantastic technology? And so starting in the summer of 2008, all weekend call was done digitally, which meant I could go to my cottage, and so could everybody else. I could even be on my sailboat if I wanted and read call as required. So let me tell you how we grew our numbers to be able to achieve the kind of subspecialty expertise that we needed. In 2006, one of the remote northern hospitals that had formed an alliance with 9 other hospitals in northern Ontario was looking for a new lab medical director. Traditionally, they had had 1.5 pathologists on site to support that entire system, but that person decided that he wanted to take a year off, and so they were left with a 0.5 who didn't want to be a lab director. So they came and asked us if we would give them coverage for the year that the person wanted for a sabbatical, and we said, well, yeah, we'll do it, but we're not happy because we'd rather do this permanently. And it ended up becoming a permanent relationship. This is a map of Ontario, and you can see here Toronto at the very bottom. This is Timmins. Each of these stars is one of the small hospitals. Actually, the Trans-Canada Highway actually runs along here, and these are all kind of strategically located hospitals along the Trans-Canada Highway. Some of them have a relatively reasonable population, and there are hospitals that do operations and so on. There are surgical suites. Some of them are really very small places where they're really positioned strategically in case of a car accident, and they're primarily emergency rooms. But the important thing is that the Timmins Hospital is quite large. Many of you may know Timmins because that's where Shania Twain comes from. And that's its biggest claim to fame. It's also a very large mining center, and the Timmins and District Hospital has a surgical pathology volume of about 10,000 surgicals per year. So this 422-mile distance didn't stop us from taking over that hospital. We started with 1 pathologist on site, the 0.5 person who I mentioned. Intraoperative consultations were supported by telepathology during his absences and whenever he wasn't on call, which was half the time. And ultimately, I think the hospital came to recognize the value of having our subspecialty model. That doesn't apply only to anatomic pathology, chemistry, transfusion medicine, hematology, pathology, you name it. So we now have a permanent relationship with this hospital. We've now been able to integrate 4 pathologists because they've grown over the time. We have 4 additional bodies because of this relationship, which adds to our critical mass for subspecialty pathology. So what we've been doing until recently was slides were shipped to Toronto by overnight courier from the northern sites. Frozen sections have been supported by telepathology with a PA on site, and our plan was that ultimately there would be no person on the ground at all times. We do make visits there regularly, but we don't need to read the slides sitting there. So our big picture model is one of teams of experts who integrate with clinical staff in priority programs, whether they're in the Toronto General Hospital, the Princess Margaret Cancer Centre, or a place like Timmins, or even Kapuskasing or Cochrane, Ontario. Because we believe that as is your pathology, so goes your clinical care. By the way, Sir William Osler, who said that, was also Canadian. So that model has actually gone over very well with our provincial government that likes the healthcare system to be faster, better, cheaper. And so we now have an additional partner that joined us in 2007, the Sault Area Hospital in Sault Ste. Marie, Ontario, right across from Sault Ste. Marie, Michigan, not far from here, is a cancer center that services much of the north. And with that affiliation using the same model, we gained another 4 pathologists. And then we ended up being joined part-time by another academic center in Ontario, which is the Queen's University Hospital, where they had 2 neuropathologists previously, supporting a relatively low volume of neuropathology. But the senior neuropathologist decided to retire, and the head of the department at that point said, I really can't afford to hire another neuropathologist, and the numbers don't justify it, but I do need to have backup coverage for when he's away at meetings or on vacation. And so the solution for them was to partner with us, knowing our telepathology support for the Toronto Western Hospital. And so we now have a partnership with them where we cover their neuropathology when that person is away. And then in 2010, we were joined by another hospital in Oshawa, Ontario. Oshawa is a large town for Ontario. There's about almost 400,000 people that live in Oshawa. And the Oshawa Hospital has an affiliation with 3 other hospitals around it, smaller hospitals, so it's a 4-site institution in and of its own right, and it's one of the larger cancer centers in Ontario. It's the 3rd largest in the province in terms of patient numbers. And so they've joined us as well with another 10.5 pathologists. So this is how we grow our model. We build subspecialty expertise, we provide faster, better care, cheaper, and our challenge now is to really implement full digital pathology for workflow from all of our sites. Now, just to give you the background on this, Timmins has a histology lab. They're able to do very high-quality H&E pathology and special stains. They don't do immunohistochemistry. Sault Ste. Marie is the same. Lake Ridge Health, on the other hand, with 25,000 surgicals a year, has a full histopathology lab with immunohistochemistry and a lot of, actually they even have cytogenetics. So our challenge now is to integrate case sign out in a full digital program from the lab to the pathologist in a manner that's totally seamless depending where the slides come from or where the pathologist is sitting. So we've taken the approach of using IT integration. We have the Cerner Copath LIS, we have the advanced barcode tracking, and so we're looking at mechanisms to try and integrate the information, and I'm going to show you a little bit of how we've been able to do this. I think in the interest of time, I'm not going to go through the workstation and all the rest, but we've got 2 systems that we are now using in our lab to try and implement this technology. One of them is the Omnix system, GE Omnix, and that's been implemented at the Timmins and District Hospital, where we're looking at, actually for the FDA, a validation study of diagnostic equivalence. The approach that we've taken is not quite what the FDA wants, and I know there's going to be a lot more discussion about that later on today, but what we're doing is we're comparing digital versus microscope for the same observer to identify any reasons why there might be discrepancies, to help develop best practice guidelines, and also, from our perspective, working with GE Omnix to give them feedback to help improve their system. And again, Andy Evans, who I've mentioned, is the PI on this study, and he will be talking more about this, I think, at the Visions Conference. He's going to give some summary of the data, but I have a little bit of preliminary data here just to show you some of what we've learned. We started actually with a scanner at the University Health Network's downtown Toronto, at the Toronto General Hospital, where the pathologists were randomly picking cases every day to scan and learn how to use this system. The GE Omnic system, you can see the small scanner that they've developed here. It also has its own integrated software, which we've been working with them to help improve as well. And so we started with this very slow process of just randomly selecting cases, but now we're into the second phase, where we have a scanner on site at the Timmins and District Hospital, where every case that comes out of the lab, as the slides are stained and cover slip, they are scanned. And they're read by the pathologist at UHN. And then we issue a preliminary report that doesn't get finalized. It's not sent to the clinicians. The slides then come overnight, as they have traditionally done, by courier, and they're read by the same pathologist the next day. And then we issue the final report. So I'm just going to show you a little bit of how we've been capturing the data. We have Cerner Copath. It's got a very nice synoptic reporting module. So we created a synoptic report, and the synoptic report basically identifies the cases that have been done using this system, looks at whether special stains or not have been done. We answer the question, can a digital diagnosis be made, yes or no? What's the concordance? That we do at the end. What's the concordance between the digital and the microscopic diagnosis? And if there's a discrepancy, what was the reason for that discrepancy? And all of the data is being captured synoptically. So just to give you some preliminary data, this is now from about 5 months ago. Can a digital diagnosis be made? Yes, the diagnosis can be made in 97% of cases. There were 3% of cases where we had some issues. In 2%, the diagnosis could be made, but there were areas of suboptimal image quality, and there was only 1% of cases where the diagnosis could not be made, and the reasons were the following. In 3 cases, the tissue was too low on the slide and out of the scan area. That's an easy fix if you teach your technologists how to do this right. In 2 cases, poor focus in an area of clinical significance, and in 1, a small area with benign fat tissue that was not captured by the scanner. So the important thing is, though, that in 99% of cases, a digital diagnosis was made. The agreements, again, 98% complete agreement. There were minor discrepancies in 12 cases. 6 of these were small pieces of tissue that were not captured by the scanner. Again, a technical issue, which I will point out the significance of in just a moment. There are some clinical scenarios where you can't use digital microscopy using this kind of tool. For example, we realized that breast biopsies where you want to polarize material for microcalcifications, you can't do that using a conventional scanner. There was one atypical meningioma where quantification of mitotic figures was a problem. One of the major discrepancies we identified was actually H. pylori on gastric biopsies, and this is an area we're still working on, whether it's scanners, whether it's the viewing by the pathologist, because there's a big difference between pathologists on this, or do we need to go to special stains routinely for all cases that are being read digitally. One major discrepancy that was not technical was on a prostate biopsy where high-grade pin was seen on a glass slide but had been overlooked on the digital slide. When they went back and looked, it was there. Tell me that's any different from what happens in slides that are read on the microscope. It's not. So here's just an image of H. pylori pointing out that there are different comfort levels amongst pathologists when they look at slides that have H. pylori. Again, dependent on the burden of organisms, dependent on comfort of the pathologist to actually zoom up, or even just to call and say, can you scan it at higher magnification? Now this is actually an interesting story because this is where the same observer doing 2 different things points out something important. This was a scan of a biopsy where a piece of tissue was noted on the glass slide that the pathologist did not remember having seen on the scan. Now you won't get this on the kind of study that the FDA is looking for. This was because one of our pathologists who actually read this biopsy has a very good memory, and the next day when the glass slide came down, he said, I didn't see that piece of tissue. It didn't happen to be important, didn't have any different diagnostic information on it, but he realized it and went back and pointed this out, and that helped Omnics to actually understand that they needed to put a patch in their scanner to fix the problem, and that issue has now been resolved. Again, going through this same study, we've been able to show that that's not happening since they did the patch. So we learned some lessons from this. Pathologists should always have the option of deferring to the light microscope. Cases most likely to require light microscopy are gastric biopsies for H. pylori and breast biopsies that have microcalcifications. And we feel that the study designed with no washout period between digital and glass and the same observer for both allowed us to help to identify problems related to the scanner that we were working with. We also learned some lessons about histology, and you can see these are actually the two labs, the Timmins lab and the UHN lab, looking at the effect of tissue and slide preparation on image quality. Clearly, this is actually, I think, an opportunity for pathology because we can use these scanners to help make our labs better, and I firmly believe that we should be having histology labs validated by objective criteria that can be obtained from a scanner to make sure that we are not compensating with our eyes for poor histology. Here are a couple of just examples of some of the histology issues: mounting media on the surface, dirt, wax on the slide, air bubbles that preclude being able to look through the cover slip, tissue placement. I mentioned that some of the tissue was off the area that was able to be scanned because of the cover slip not being there. All of these are issues that are easily remedied by having our histology labs do a better job and provide a quality product. Here's some microtomy issues, tissue folds. Again, remember, when you're using a light microscope, you can focus up and down through those folds. When you're using a scanner, you can't. Should we be doing that, compensating? I think we shouldn't, but anyway. And I already mentioned the issue of beta site product improvement with the rescanning and the patches that have been identified and put in place to improve the Omnix scanner. So currently, we have 2 Omnix VL4 scanners up at Timmins. We're putting through about 500 slides per day. We're measuring scan time and rescan rates. We have a full APLIS integration pending. That has not yet happened. The Omnix product is not yet fully integrated with the Copath APLIS. And we continue to ship the glass and doing the glass reads the next day. But we're also monitoring the turnaround time reductions that would be done, or that would be possible once those digital reads are performed. Now, Lakeridge, which is the large center that's about 40 miles from downtown Toronto, we're doing a different process with them. We have one Apereo ScanScope AT400. It's a machine that we know very well because we've been using it at the UHN for research and diagnostic purposes. We have one full-time scanner who's operator at that site. And there we're hoping to scan, again, about 500 slides per day. What we have there is we have a model where on-site we have folks doing GI, GU, and breast because they're enough high volume to actually keep people busy there full-time. But all of the other subspecialties don't necessarily have someone on site. It's a very large lung cancer center. They have a fair number of liver biopsies. All of those currently, or until currently, have been done by shipping glass slides. It takes about 3 hours to send the slides downtown. Every day there's one shipment when the work comes off the and is completed and packaged and shipped. But what we're planning to do there is to have the Apereo integration running and not package slides and send them. This is not a validation study. It's strictly patient care. We do not have to produce data from this, and so we're just going full steam ahead to do subspecialty diagnostics in that model. Now, I just wanted to spend a couple of minutes to do due diligence to Quebec. My colleague there, Bernard Tetu, has presented some data which he shared with me, and I'm really showing his slides. But I just want to point out that Eastern Quebec is very similar to Northern Ontario in that when you leave the Montreal and Quebec area, you end up with a very large geographic area that has a lot of dispersed small hospitals that do not have pathologists on site. There are surgeries going on in some of these centers, and the surgeons were complaining about having to do a large number of two-step surgeries. They couldn't do frozen sections intraoperatively, so they would have to bring the patient back when sentinel lymph nodes were involved. Patients had to be transferred from some sites to larger centers if frozen sections were deemed to be necessary during their care, and it became very difficult for the province to recruit surgeons to some of these remote centers. The pathologists who were in those centers were very insecure, especially because many of them were recruited immediately out of training to centers where people were offering them a lot of money to come and work because they needed them there, but they were not very happy that they were isolated and on their own having to make hard calls. They weren't able to get second opinions in a timely fashion, and they couldn't be absent without really, telling the whole organization to shut down. So the province of Quebec decided to implement this population-based, patient-oriented solution using telepathology to provide intraoperative frozen sections anywhere in the province at any time, and to allow on-site pathologists to get second opinions where they needed them. And also, many of those hospitals, of course, would not have an immunohistochemistry lab. When they needed immunostains, they would send the slides off to a larger center that would do the technical work, and then the slides were sent back for their interpretation. They also decided that they could use this to digitally transmit the slides back to them. The Quebec Ministry of Health and Canada Health Infoway have basically sponsored this project in 24 sites across the province, and you can see here the distribution. 7 hospitals that don't even have a pathology laboratory could provide at least intraoperative frozen sections. 17 sites with a pathology lab, 4 of whom had no pathologist on site. So basically, the technology that they've been using is all shown in this diagram, and I can't speak to their technology because I've never used it myself, but this is just an example from one site, Sept-Îles, where there's a surgeon, to Quebec City. These are their statistics. They've done 7,000 primary diagnostic scans, almost 500 intraoperative frozen sections, 500 expert opinions between pathologists, and then 166 instances where they've just helped with macroscopic evaluation of specimens, and 150 immunos sent back to pathologists in a remote site. Their concordance numbers are just like ours, 98%. That seems to be the magic number. They had a learning curve time, which we actually had similar experience with, although I think we did a little bit better and faster, maybe reflecting the young age of my department compared to the Quebec group, but you can see they're down now to 16 minutes. They feel that this has offered major benefits to them in terms of the ability to get faster diagnosis, support frozen section coverage, not have to have patients travel or surgeons shut down their practice. The expert opinions allow faster, better care for the patients in the remote sites. They're able to do real-time communication with to a technologist and also to a surgeon in one of the smaller hospitals. And basically, they've also seen the advantage to standardization of technical processes. So I think I'm just going to finish now because we're getting a little bit late. I want to just talk a little bit about where we're going. I think you can appreciate as an audience that we in Canada don't have the FDA stopping us, and we are moving to implementation of full digital pathology as much as we possibly can. I see this as being an opportunity for us to move to more computer-assisted diagnostics, which I think we definitely need. There's no question that inter-observer variability and so on is a major problem in pathology, but I think there are a lot of other tools that are going to help us, things like counting mitoses and Ki-67 labeling indices, the immunohistochemical evaluations that we in Canada have had a lot of negative press about because of interpretation issues, and also I think the quality of technical material. I think we are moving to an era where we need to be looking more at Westgard rules for pathology the way we have in chemistry and hematology. And I think this is an opportunity for us to do this with our vendor colleagues. The critical requirement, of course, is business case. It's always about money. And in our public health care system, we are looking at this very carefully because we don't have any extra money. We don't have profits. We have to invest our money as wisely as we can. And that's why we've moved to the model we have on the reading side. And in terms of being able to do this digitally, we are actually looking at how much money can we save by not having to go looking for slides. When they're in the system and you click on a case, they're there. You don't have to hire a clerk to go and look for slides that are misfiled in the slide library. Matching slides to the case. Every time a case comes out and there are immunos to go and put into that case, you got to pull back the slide tray, file everything in the right place, and send it back to the pathologist. That costs money. Shipping slides for us. We've got great experience on shipping slides for the last 6 years around the province. And by the way, I have not calculated the medical legal risk of having lost slides, which has happened to us once. And then, of course, retrieving old slides for post hoc review. A patient comes back with a tumor and they've had a history of cancer. cancer, and you need to compare, is it the same as the previous, or is it a new primary? All of those things cost money. We also are looking for opportunities in new markets, and our institution now has a relationship with the Kuwait Cancer Control Center, and we are performing digital consultations for them on a regular basis as part of our program. We have folks on the ground who are helping them to run their labs, but these are all technical and quality folks. The pathologists are all in Toronto. So digital secondary consultation, I think also, you know, what does digital pathology do? It enables immediate access to the right pathologist at the right time, whether it's in Ontario getting the right expert to read that slide first, or whether it's a matter of sending our slides to an expert who's only seen the one reported case of whatever we think this is somewhere else in the world. This is highly cost-effective for us, and I firmly believe that, as was said earlier, we need to take control here, because the best way to predict the future is to invent it. And despite the FDA, I think we are trying to invent digital pathology as our future in Canada. And I'll just finish with photos of the two folks who did all the real work that I'm telling you about today, Andy Evans in Toronto and Bernard Tétu in Quebec, who provided me so kindly with his slides. Thank you. Yes? Time for a couple of questions, if there are.
We have a computer switch, so we'll take a couple questions.
An excellent talk, but I'm just wondering about the quality assurance you're going to put in place for when you're totally virtual from that one hospital, that you're not going to be shipping the slides?
So we do routinely 20% QA on all of our cases, and that is going to be continued with glass slides as the backup for those cases in the interim until we gather the data.
So you showed data that said 90% of your frozen sections were neuropathology, and I'm not a neuropathologist, but I know the squash preps, the cytology is sometimes more important than the frozen. So
we do those too. We scan the squash.
On the
yes.
quality of the cytology?
We do this. We do squash preps routinely on all of our neuropath, and those are scanned, and we look at them. And I can tell you that the image quality is great, and I have some beautiful photographs I could share with you.
And since you're not necessarily beholden to the FDA, in your opinion, is a frozen section diagnosis a primary diagnosis?
It certainly is.
Since you had a sequence of reading by the same person, the order can affect the outcome. Was the physician who read these slides blinded as to whose slide it was? They probably could recognize the slide sometimes, but if they didn't know the name of the patient or there were no markings on them, it would make it a better comparison.
These were not blinded. They were the same pathologist reading the original slide and reading the glass slide.
Did they know that it was a name that they could recognize, perhaps, or was it they didn't know who the patient?
Yes, it was not blinded. These were handled as regular sign-out cases where you had the case open in front of you, and we asked people not to look at their original report when they looked at the slides, but that was not the point of the exercise. It was really the validation of the primary read. So we were looking for things that could have been missed on the primary read.
This is sort of a related question. Did you have the opportunity to do it in reverse, namely have the pathologist look at the microscope, then the digital, to see whether or not you can pick up additional information, i.e. whether digital pathology might be better?
That's a great question. We haven't done that as a formal study. We have been doing it. We've asked folks to do that primarily on our consultation cases, where we read the glass slides first. When people send us consults, we've been now scanning them into our system because we return the slides back to the original owners. And so we've asked folks to go back and do some of those comparisons, and I can tell you, we haven't collected the data yet, but I can tell you in a case where I looked at it, in one of mine, I actually saw a micrometastatic papillary thyroid cancer in the digital that I did not see on the glass. Now, that's an N of 1. As I said, we haven't analyzed the data, but I'm a firm believer that, yes, that study should be done, because I think it's actually better depending on the scanner you're using.
Well, it's important because even ignoring fancy computer-assisted technology, just the ability to increase contrast or use false color should make things a lot simpler.
Exactly, exactly. I agree with you. We haven't been contracted to do that study formally, though. Thank you.